Throughout my 4 years at IPS, there are always a few things you could count on. The Wi-Fi not working, Piper being late, and someone always asking you, what are you going to do for your Masterworks? For the first few years, I would always say something like, that's a long way away, I'm still thinking about it, trying to avoid the question, because truthfully, I had no idea. And you know, my evasion tactics worked pretty well until it was September of grade 9, and once again, we were being asked what we were going to do. Except this time, I had to pick. But what started as a cool idea quickly turned into staying up till 2 a.m. 5 nights a week, and yes, finding really interesting facts, but also falling deeper and deeper into a rabbit hole I never even knew existed. But before we get into any of that, has anyone here ever heard the term intracranial neoplasm? No? Shocking. What about brain tumor? Yeah, okay, there we go. Well, surprise, they're actually the same thing. But what actually is a brain tumor? Anyone want to take a shot at it? Not you, Allison. Any sciencey people? Put your hands down. We'll just ruin my Masterworks. Okay. Anybody? Wyatt. Perfect. Most of us probably just thought it's a tumor in the brain, obviously. And yeah, that's technically true, but what if we dive deeper into that question? Well, that's what I've been doing this past year, and today I'm going to share what I learned with you. Hi, I'm Mischa LaRoche, and this is my Masterworks, a closer look, exploring the biology and impact of brain tumors. I can't see my script. In this presentation, I will be covering what brain tumors are and how they form, a few specific types of brain tumors, how they affect both the body and the mind, and finally, how they're diagnosed and treated. To understand all of this, we first need to start at the root of the problem, what a brain tumor actually is and how it forms in the first place. A brain tumor is an abnormal growth or mass of cells in the brain, around it, or in and around the spinal cord area. These tumors can be either non-cancerous or cancerous. The growth of these tumors can disrupt normal brain function by putting pressure on surrounding tissues, leading to a variety of symptoms that I will go over later on. But when does a brain tumor actually become a brain tumor? Well, it all starts in the cells, when normal, healthy cells start to turn into a cancer cell. Let's go over how this happens and what are some of the signs. Cells become cancerous when their DNA gets damaged and stops working properly. We all know what a blueprint is, yes? Okay, good. Well, DNA contains genes that act like blueprints for making proteins, which control how cells grow and divide. Mutations or changes in DNA can happen due to factors such as smoking, radiation, or excess sun exposure. DNA mutations can cause the body to produce too many or too few proteins, or even faulty ones that don't work properly. Since billions of cells divide every day, mistakes in DNA can sometimes even happen by accident. If a cell gets the wrong mutations, it may start growing out of control and become cancerous. Cancer cells can be fully classified as a tumor when they begin to pile up and clump together, creating an abnormal mass or growth. Okay, let's be real. Under a microscope, most cells just look like blobs. But cancer cells, they stand out. Think of them like a teenager. Messy, rebellious, and completely ignoring the rules. While normal cells are structured, polite, and know when to stop, cancer cells are the ones blasting music at 2 a.m., skipping curfew, and refusing to clean their room. And okay, to more of you guys, I know we aren't actually like this, but this is basically how the older ones see us. So it'll make it easier to explain. Just bear with me for a second and accept the stereotypes for a bit. All right. First off, we have appearance. Normal cells look neat and organized under a microscope. Cancer cells, not so much. They're all over the place. Uneven shapes, sizes, and a messy structure, like a teenager's room. Next, we have growth. Normal cells know when to stop growing, like a responsible kid who knows their limits. Cancer cells just keep going, growing, and dividing nonstop. Next, we have contact inhibition. Regular cells respect each other's space and send signals to stop crowding. This is called contact inhibition. But cancer cells, they ignore personal space completely, piling up and causing chaos. Homeostasis and apoptosis. Homeostasis is how the body keeps all of its processes functioning and operating. When normal cells get old or damaged, they either fix themselves or go through apoptosis, which is basically just like cell death. Cancer cells can dodge both, like a teenager avoiding responsibility, and they stick around way longer than they should. This p53 is a tumor suppressor gene. Think of it as like the hall monitor protein that checks for damage. If something's wrong, it tells the cell to shut down. But if the p53 gene is mutated, it's like the hall monitor's gone, and the troublemakers, or the cancer cells, run wild. Sticking. Everyone here likes to travel, yes? Yeah. Yay, you're like a cancer cell. Normal cells can make a glue-like substance that keeps them in place. The cancer cells are like teens skipping class, wandering off and spreading to other parts of the body. This is also known as metastasizing. The immune system. The immune system targets and destroys normal cells when they become damaged or injured. However, cancer cells can evade the immune system by tricking it into leaving them alone until they grow into a full tumor by releasing chemicals that suppress immune cell activity. And our last one, angiogenesis. Angiogenesis is when the body grows new blood vessels to bring food and oxygen to tissues. Normally, blood vessels only grow when needed, like during healing. Cancer cells can trigger angiogenesis even when it's not needed, helping tumors grow. This is like a teenager constantly getting DoorDash or Uber Eats. A prime example of this is Jua spending $14 DoorDashing Takis to her house. True story. Okay, hold on, just like 1 second. Okay, now that we've covered the basic biology of tumors and cancer, let's move on to looking at a few different types of brain tumors. Understanding the different classifications of brain tumors is crucial because it helps us determine how a tumor behaves, the symptoms it might cause, and what treatment options are available. Brain tumors can be grouped into two wide categories: primary tumors, which start in the brain, and secondary, also known as metastatic tumors, which are cancers that spread to the brain from somewhere else in the body. Tumors can be further classified as either benign, meaning non-cancerous, or malignant, meaning cancerous and usually more aggressive. In this section, I'll be focusing on three specific types of brain tumors: meningiomas, pituitary tumors, and glioblastomas. Meningiomas are one of the most common types of benign brain tumors. They usually form on the outer layers of the brain, which is all of that stuff right there, and they tend to grow, on the base of the skull, and they tend to grow pretty slowly. Because of the growth, symptoms often don't appear until the tumor is quite large. While that delay in symptoms can sometimes make them life-threatening, this isn't very typical, and more than 60% of people diagnosed with high-grade meningiomas survive for at least 5 years. Meningiomas are classified into 3 grades to describe how fast they grow and how likely they are to spread. These grades are grade 1, grade 2, and grade 3. Grade 1 meningiomas are the most common, covering about 80% of cases. These tumors are benign, slow-growing, and don't usually spread to nearby brain tissue. Most grade 1 tumors are treated with surgery or radiation and have a strong prognosis with a low chance of coming back. Grade 2 meningiomas account for about 17% of cases. These tumors still fall under the benign category, but they grow more quickly and can become malignant over time. They may begin to press into nearby brain tissue, making them harder to fully remove. Treatment usually involves surgery and radiation, but there is a higher risk of the tumor returning. And finally, grade 3 meningiomas, also called anaplastic meningiomas, which are rare, and they only account for around 1.7 of meningioma cases. These tumors are malignant, they grow quickly, and they can spread into the brain or even beyond. Because of how aggressive they are, they're usually very hard to treat and often require surgery. Radiation, and sometimes chemotherapy. Symptoms of a meningioma depend on where it's located in the brain, and they usually come on slowly. These might include vision problems, memory issues, weakness in the limbs, or trouble speaking. If someone starts having seizures or has a sudden noticeable change in their memory or vision, they should get medical attention right away. Okay, oh no, yeah, that's right. Okay, now we know about meningiomas, let's move on to pituitary tumors. Pituitary tumors develop in the pituitary gland. Wow. Basically, it's a teeny tiny organ deep in the brain, right behind the bridge of your nose, which is that red thingy right there. It plays a major role in controlling the body's hormones, including those from the thyroid, adrenal glands, and reproductive organs. When a tumor grows in the pituitary gland, it can interfere with hormone levels. Usually, these tumors only affect one hormone, and they're named based on which hormone they impact. For example, a somatroph adenoma affects the growth hormone, and a thyrotroph adenoma affects the thyroid-stimulating hormone. I could honestly write a whole other Masterworks just on pituitary tumors, but for this project, I'll be focusing on two: microadenomas and macroadenomas. Both of these are benign tumors, but they can still have some really unique effects on the body. Microadenomas are pituitary tumors that are measured over 1 centimeter in size, and they can either produce hormones, making them functioning, or not, making them non-functioning. Because of their size, they can put pressure on surrounding structures, leading to symptoms like headaches. Oh, that's totally in the right spot. Like headaches, vision problems, sinus or facial pain, drooping eyelids, seizures, nausea, and vomiting. They can also disrupt hormone production, which might cause tiredness or energy loss, changes in the menstrual cycle, weight changes, and other hormonal symptoms. Microadenomas, on the other hand, are smaller than 1 centimeter and can also be either functioning or non-functioning. Most of the time, they don't cause any symptoms and they don't need treatment, but if they do, they're mostly the same as the ones caused by macroadenomas. In many cases, pituitary tumors are actually found by accident during an MRI or CT scan done for a completely unrelated reason. If the tumor isn't causing any problems, treatment isn't usually needed. Symptoms typically happen either because the tumor is pressing on nearby structures or because it's causing an imbalance in hormone levels. Okay, I want everybody to try to say that word, the top one. Okay. Yeah, I had a pretty similar experience. This is called the adrenocorticotropic hormone, or in simpler terms, the hormone that controls cortisol production. If there's too much adrenocorticotropic hormone, from now on we're calling it ACTH, the body will make too much cortisol, leading to a condition called Cushing's disease. This can cause thin skin, stretch marks, acne, weight gain, rounder facial features, and excess body hair. People might also have slower wound healing, muscle loss, and just feel generally unwell. Another hormone that can happen, hormone imbalance that can happen, is related to the growth hormone. Somatroph adenomas can cause too much growth hormone to be produced, leading to a condition called acromegaly. This can cause facial changes like a longer jaw or larger lips, joint pain, thicker skin, deeper voice, and larger hands and feet. In kids and teens, this can cause gigantism, which means unusually rapid or excessive growth. So now that we've talked about meningiomas and pituitary tumors, let's get into the last type in this section, glioblastomas. Glioblastomas are extremely aggressive brain tumors that start in the brain and more rarely the spinal cord. They're known for being very fast growing and extremely difficult to treat. They damage healthy tissue as they grow, and even though they can happen at any age, they're most common in adults. Symptoms usually show up as worsening headaches, nausea, vomiting, vision problems, so like double or blurry vision, difficulty speaking, and changes in the sense of touch, and sometimes seizures. Glioblastomas are responsible for about 50% of all malignant primary brain tumors. Despite being known since the 1920s, only 4 drugs and 1 device have been FDA approved, specifically to treat glioblastomas, and even those have failed to extend the patient's life expectancy further than a couple extra months. The best outcomes are typically seen in people under 50, those who are generally healthy, and patients with specific genetic markers. Now that we've looked at a few specific types of brain tumors and how differently they can behave, let's talk about what actually happens when someone has one, the symptoms and the effects they can have on the body and brain. Brain tumors can cause symptoms because of how and where they grow. Because the skull is so hard and inflexible, it doesn't allow the tumor to expand properly, which can cause the tumor to expand into the brain instead. This can then lead to the tumor pressing on any nerves, blood vessels, or tissue surrounding it, which can have huge effects and impacts on someone's body, health, and brain functions. Brain tumors can directly invade and destroy healthy brain tissue, putting pressure on nearby areas and increasing intracranial pressure, which can impact brain function. They might also block the normal flow of cerebral spinal fluid, or CSF, leading to the enlargement of spaces in the brain. In some cases, tumors can even cause bleeding, resulting in serious neurological consequences. Depending on their location, brain tumors can affect different bodily functions. This is because various areas of the brain are responsible for controlling specific parts of the body. A helpful way to understand this is through the cortical homunculus. It looks a little bit like a sleep paralysis demon, but it's basically just a visual representation of how different regions of the brain's cortex respond to movement and sensation in different body parts. For example, if a tumor develops near the area of the brain that controls hand movement, a person might experience weakness in the hand, clumsiness, or even seizures involving the hand. Similarly, a tumor affecting the part of the brain associated with facial muscles could lead to facial drooping or difficulties in speaking. While the symptoms may vary, they generally reflect the function of the brain region where the tumor is located. So, after all of these symptoms show up, how do doctors actually figure out if someone has a brain tumor? That's where the diagnostic process begins. Brain tumors are diagnosed through a series of tests. A doctor will first ask about the patient's medical history, which might include questions like, what symptoms are you experiencing? Is there any history of cancer, brain injuries, or neurological issues in you or your family? What medications are you taking? And do you have any other health conditions? This is then followed by performing a general physical and neurological exam, which will check things like their coordination and balance, reflexes and muscle strength, sensory function, and also their mental status. If a doctor suspects that their patient has a brain tumor, scans are typically organized within 48 hours of the tests. There are many types of imaging processes that can be used for detecting brain tumors, but the most standard one is an MRI. Other common imaging tools include PET scans and CT scans. Once a brain tumor has been identified, a surgeon will go in and try to remove a piece of the tumor to be looked at under a microscope. This is called a biopsy. During this process, they'll usually try to resect as much of the tumor as they can, and in some cases, this may not be safely possible due to the tumor's location in the brain or spinal cord area. This stage is the first and most important step of the diagnostic process, because not only does it help them fully diagnose the tumor, but it can help them relieve pressure on the brain, which can also help with symptoms. Imaging tests and other procedures can sometimes indicate a high likelihood that the tumor is benign and a biopsy isn't actually performed. Okay, now we know how doctors find and diagnose brain tumors. The next step is figuring out how to treat them. This often involves a combination of surgery, chemotherapy, and radiation. But first, let's dive into the important role imaging plays in guiding these treatments. Just give me a sec. Okay. Once a brain tumor is suspected, imaging plays a critical role in both detection and treatment planning. Okay, let me ask you all a question. If you had a brain tumor and you were going through the treatment process, which of these three images would you want the doctor to be looking at to find your tumor? 1, 2, or 3? Dorian? Okay, well, if you picked number 1, you'd be right. This is called an MRI, and it's the most commonly used and most detailed scan. However, all brain scans are important because they show different things. MRIs give detailed images of soft tissue. CT scans are fast and show bleeding or swelling, and PET scans help to show how active the tumor is. Doctors often use a mix of scans to get the full pictures. I'm not going to go over CT scans and PET scans in detail right now because I want to focus primarily on MRI scans, which are the main ones used for brain tumors. But if you are curious about them, feel free to ask about them at the end. But for now, let's learn more about MRIs. An MRI uses a powerful magnetic field and radio waves to create high-resolution images of the brain. Unlike X-rays or CT scans, it doesn't use radiation, which makes it safer, especially for repeated use. In many cases, a contrast dye is injected into the bloodstream beforehand to help distinguish abnormal tissue from healthy brain structures. This contrast enhances the visibility of smaller tumors and gives the clearest picture possible. An MRI is often used to detect brain tumors because it gives clearer images of the brain than other imaging tests, so the doctors can diagnose a brain tumor more efficiently. There are also special types of MRI scans. Oh, I was totally on the wrong slide for that. Whoa, guys, I totally got this figured out. There are also special types of MRI scans that can provide even more details. A functional MRI, or an fMRI, magnetic resonance spectroscopy, you get it, or MRS, and magnetic resonance perfusion, or MRP. These are all special types. I'm not going to go into detail because I don't really have time, but yeah. Once a tumor is identified, surgery often becomes the next step. Okay, I'm going to walk you through a simplified version of what brain tumor surgery might look like, more specifically a craniotomy, which is a procedure where a part of the skull is temporarily removed to access the brain. Like most surgeries, this one starts with the patient being placed on the operating table and given general anesthesia, usually through an IV or sometimes through a mask. This puts them completely to sleep. Once they're under, a 3-pin skull fixation device is used to keep the head completely still through the procedure. Even a millimeter of movement could be dangerous. That's that thingy, the one that looks like a medieval torture device, that one. Sometimes the surgeon will also go in and give mannitol, which is a medication that relaxes the brain and helps reduce swelling. This area is then disinfected using an antiseptic solution, and the surgeon makes an incision, often just behind the hairline to reduce visible scarring. They carefully separate the skin and muscles from the skull and fold it back. Then, using a drill, they make small holes in the skull called burr holes. These burr holes are connected using a tool called a craniotome to cut out what's called a bone flap, which is basically a section of the skull that's temporarily removed to access the brain underneath. This bone flap is set aside and will be put back at the end of the surgery. Beneath the skull is the dura, which is the protective covering of the brain. It's carefully opened and retractors are placed gently to hold back brain tissue or structures. At this point, the surgeon might use magnifying tools like loupes or an operating microscope to get a closer look at the area. Brain tumors can be deeply embedded in the brain, so this step is all about precision. Then they use extremely delicate instruments like long scissors, dissectors, or sometimes even lasers to either collect a biopsy sample or start removing part of the tumor. One of the most advanced tools, and something I think is actually really cool, is called an ultrasonic aspirator, and that's that thingy right there. So basically it uses sound waves to break down the tumor and like all the soft tissues, and then suctions it away at the same time. In some cases, the patient is actually kept awake during the surgery. This is called an awake craniotomy. Surgeons can talk to the patient and ask them to speak, read, or move specific body parts. This is done to make sure no critical parts of the brain are being damaged while the tumor is removed. All right, once the tumor has been safely removed or the biopsy is done, the retractors come out and the dura is sewn shut and the bone flap is screwed back into place using small titanium plates. The muscle and skin are stitched together and finally a soft dressing is placed over the incision site. After surgery, the patient is moved to recovery to be monitored as they wake up. The next steps will depend on the type of tumor. Some are benign, while others may require follow-up treatments like chemotherapy or radiation. Surgery is not the only option for treating brain tumors, however. Some tumors either don't require surgery or are inoperable because of their location or size. Instead, patients will often be treated with chemotherapy or radiation therapy, which brings us to our next treatment option, chemotherapy. Chemotherapy is a common type of cancer treatment that involves taking some form of medication to kill cancer cells. Treatments like surgery or radiation are often paired alongside chemotherapy to maximize results and kill the cancer cells more efficiently. Researchers and scientists have discovered many ways to deliver chemo drugs into the brain. It's most commonly administered through a pill, a vein in the arm, which is called an, a vein in the arm, which is called an IV, directly into the CSF, or cerebral spinal fluid, or as a surgically implanted wafer in the brain. Now, although chemotherapy can be effective because it targets quickly growing and replicating cells, which are usually cancer cells, it can also sometimes damage normal cells unknowingly. This can result in various side effects. Let's go through some of the most common ones. Starting off with a common side effect of chemotherapy is low blood cell counts. Chemotherapy can suppress bone marrow function, which reduces the production of white blood cells, red blood cells, and platelets. A low white blood cell count, known as neutropenia, increases the risk of infection. A drop in platelets can lead to something called thrombocytopenia, which can make it easier for one to bruise or bleed, even just for minor injuries. Pretend those are switched. Low red blood cells, or anemia, can often cause fatigue, shortness of breath, paleness, and dizziness. You can really tell I've got all these slides figured out. Next is hair loss. Since chemotherapy targets rapidly dividing cells, it often affects the hair follicles, leading to partial or complete hair loss. This typically begins 2 to 3 weeks after treatment starts, and hair usually grows back after chemotherapy ends, although in some cases, like with very high doses used for stem cell transplants, or sometimes when using a type of chemotherapy called docetaxel, even in standard doses, hair loss can be permanent. Fatigue is also very common, and not just general tiredness, it's a deeper and more persistent form of exhaustion. It's often related to anemia, but can also be a result of the toxic substances breaking down in the body from dying cancer cells. The fatigue will usually occur for a few days following treatment and can be enhanced if the patient has other treatment plans alongside chemotherapy, such as radiation therapy. Nausea and vomiting are also frequent side effects. These can begin within hours of treatment or in some cases appear later, known as delayed nausea. While these symptoms can be challenging, anti-nausea medications are often used to help manage them. And finally, appetite changes. Chemotherapy may affect a patient's sense of taste or smell, making food less appealing. Nausea or fatigue can also reduce the desire to eat. As a result, many patients lose weight, even though maintaining proper nutrition is crucial for healing and recovery after treatment. In many cases, chemotherapy is only one part of a larger treatment plan. Another critical method used in managing brain tumors is radiation therapy, especially when surgery isn't an option, or when the goal is to target any remaining tumor cells post-surgery. Let's take a look at how it works, the different types of radiation techniques used specifically for brain tumors, and some of the effects. Radiation therapy is a type of cancer treatment that uses X-rays to get rid of malignant cells in brain tumors or slow the growth of benign ones. There are different types of radiation therapy depending on the tumor and its location. The most common type is called external beam radiation therapy. This method directs high-energy beams at the tumor and sometimes the tissue surrounding it. In some cases, especially when multiple metastatic tumors have spread throughout the brain, doctors may recommend whole brain radiation. This allows them to target not only visible tumors, but also tiny ones that might not show up on scans. Okay. Another common and highly effective type is called stereotactic radiosurgery. Despite its name, it's not actually a surgery. It delivers smaller and more precise radiation to a tumor while avoiding healthy brain tissue. This makes it very useful for treating tumors in hard-to-reach or more sensitive areas in the brain. Lastly, and personally the coolest in my opinion, is proton therapy, which is a much more precise type of radiation that uses protons instead of regular X-rays. It's kind of like aiming a laser at the tumor while avoiding everything around it. That means less damage to healthy brain tissue, which also means fewer side effects. It's super helpful when tumors are near important things like the brain, the heart, or your lungs, like basically anywhere you really don't want radiation messing up. Oops, yep, totally got that. Of course, like any treatment, radiation therapy comes with potential side effects, and these can vary depending on the location of the treatment. But since we're focusing on brain tumors, let's look at the side effects specific to radiation on the brain. One of the most common side effects, which I'm sure you've been hearing a lot in this presentation, is headaches, which can be caused by swelling in the brain due to radiation. That swelling can also lead to nausea, vomiting, and in some cases, seizures, all symptoms that require close monitoring by medical professionals during treatment. Radiation can also lead to hair loss, similar to chemotherapy, but with one important difference. It only affects the area where the radiation is being targeted. So for brain radiation, that usually means localized hair loss on the scalp. The amount of radiation, the amount and performance of, oh my goodness, sorry. The amount and permanence of hair loss also depends on the dose and length of treatment. The last one is skin problems, and while they're more common when radiation is used on other parts of the body, patients receiving radiation might still experience dryness, redness, or itchiness on the scalp where treatment is applied. These skin reactions usually appear within the first 2 weeks of therapy. Overall, the whole treatment process, from your first exam all the way to finding out your treatment route, helps doctors and patients work together to understand what's going on and figure out the next best steps. It seems complicated, and it totally is, but each part is crucial to making sure the right decisions are made. Okay, finally, after a long presentation that I'm sure most of you were half conscious for, and I apologize for choosing such a big topic, let's move on to my final conclusion. From the physical and psychological tools to the advanced diagnostic and treatment methods, understanding brain tumors helps us appreciate the resilience of the human brain. Brain tumors are incredibly complex and can affect many parts of a person's life, physically, mentally, and emotionally. Through this project, I explored what causes them, how they're diagnosed, and the main treatment options like surgery, chemo, and radiation. While treatments are challenging and can come with many side effects, there are constant advancements being made in medical technology and research. Understanding the science behind brain tumors has given me a better appreciation for how far we've come in medicine, but also how much more there is to discover. Even though there's still a long way to go, there's a lot of hope in the progress that continues to be made. Working on this Masterworks has been a really valuable experience for me. Choosing to focus on brain tumors pushed me to explore a topic that's both medically complex and personally interesting to me. Throughout the process, I learned how to take scientific information and turn it into something hopefully semi-comprehensible. It's also helped me get a better idea of what studying and working in the medical field might actually look like. From researching, writing, and revising to preparing for my final presentation that I finished a solid 8 hours ago, this project has helped me feel more confident in my interests and the path I want to take in the future. If you're all still awake, congrats, we've made it to the end. Although this was probably a lot to take in, and let's be real here, most of you have probably forgotten half the things I said, I want to give some acknowledgement to everyone who helped me out with my Masterworks throughout this whole year. First, I want to thank my internal advisor, Allison, for being so helpful and providing me with information and ideas for my Masterworks. Thank you for taking the time out of your, nope, that's the wrong one, for first off helping me actually pick my topic, but also keeping me on track, reading through my pages and pages of research, and making my Masterworks possible. So thank you. Next, I want to thank Simon, my external advisor, for being so helpful and providing me with information and ideas for my Masterworks. Thank you for taking the time out of your incredibly busy day to meet with me and help me through the whole process. Also, this is the only photo I could find of you, I'm sorry. I also want to thank Jen, of course, for supervising our whole class and keeping us somewhat sane no matter how behind we were or how chaotic things got. You were there for every single one of us throughout this entire year and kept us alive and working through sheer force of will while we self-sabotaged at every possible turn. Thank you to my mom, who despite pushing her away every time, still checked in with me to make sure I wasn't too stressed out and was actually doing my Masterworks. Without you breathing down my neck about it constantly, I probably would be standing up here with little to nothing prepared. Thank you to my classmates who trauma bonded with me through late night work sessions, procrastination, and pure panic. You guys didn't actually do much except remind me of the impending deadlines, but at least we were all spiraling together. And finally, thank you to you all for sitting through this presentation. Hopefully it wasn't too boring, because without you, my presentation might be a little depressing, as I would be talking to Simon, Allison, Jen, and that statue back there. Yeah. What? Oh, yeah.
Ms. LaRoche, an incredible presentation, and despite what you're saying, I think that was very accessible to a lot of people. So I'm hoping that you guys have some great questions, but we are going to start with the experts, and that is your advisory panel.
Great. That's so exciting.
Ms. LaRoche, wow, that was incredible. I can't even describe how proud I am of you. As you all saw, she took on a really big topic, and at the beginning of the year when we were deciding, Miss LaRoche was like, I'm debating between string theory and neurosurgery. And I was like, whoa, you're incredible already. So you took a vast amount of research and you delved into so many different topics, and you always came to me like, oh, this is really cool. This is a really interesting thing that I found. And I know you couldn't include all of those things in your paper and in this presentation. I know we had to cut down a lot for this presentation, but my question to you is, what is something that excited you or interested you in your vast amount of research that you did that you weren't able to include in either your presentation or your paper that you'd like to share with us?
Yeah. Okay, so actually, I have something that's like really cool to me, and I'm probably gonna sound like a total nerd talking about it, but it's this thing called neuroplasticity, which I got a lot of questions of people being like, so like what happens when you take out a brain tumor and there's this big hole in the brain? I was like, that's a good question. So anyway, I was reading this book called The Brain That Changes Itself, and it's basically like a collection of a bunch of people's really cool brain stories. And one of them is about this girl who was born with half a brain, and you would totally think like, oh, she's not going to be able to do anything ever, but her brain actually rewired itself to work properly, like and function like a normal brain, which I think is like really cool, that your brain can like manipulate itself, I guess, and like work around all the challenges and like function normally, even if there's like a big stinking hole right in the middle of it. And I didn't actually get to put that in my research paper, but it's definitely something I think was really, really cool.
Thank you.
Ms. LaRoche, that was a fabulous presentation. I mean, if I had received that in first year medical school, I would have been through the roof, absolutely through the roof. So that is just a well done synopsis. I have two questions. First one is, did you discover something unexpected during your research process? That's the first one. Mm-hmm. And then the second one is, what do you think will be on the forefront for treating those nasty malignant glioblastomas, which historically have done poorly?
Yeah, for the first one, it seems kind of like basic, but I didn't realize how many types of brain tumors there were. Before I had done any research and like started this project, I was like, oh yeah, brain tumors, there's like, I don't know, maybe like 3 or 4 types. There's over 120. And it was also really interesting learning how diverse all of these types of brain tumors are and how they can all have like different effects on the brain and require different treatments. And it also, I think, helped me understand why finding treatments for brain tumors is so much more complicated, because it's not really like a one-size-fits-all situation. Each like type of brain tumor needs its own individualized treatment. Oh, and the second one, I think the next big step in treating glioblastomas could be like targeted immunotherapy, which basically it's like instead of giving everyone the same treatment, it's personalized to like each person's tumor based on their genes and their immune system. It's already being used in other type of cancers, but scientists are also trying to make it work for brain tumors as well. The only challenge with it is getting the medicine actually into the brain because of the blood, what's it called, the blood-brain barrier, which blocks most things from getting in. But if researchers can figure that out, then I think it would be a really useful and big breakthrough.
Questions from the floor.
You did really well, Miss LaRoche, and I'm wondering, is a CAT scan different than a CT scan, or are they the same thing?
I think they're different. I'm actually not entirely sure because I didn't look into anything further than those 3, but I would assume so, since they have different names and they probably stand for different things. Is this true? Or are they the same? Oh, JK, they're actually the same.
Call a friend, call a friend.
Awesome.
I have a question for you,
Mm-hmm.
and it's on the same bent as Alara's. The CT scan was the one that was in color, right?
No,
What's the one in color?
PET scan.
The PET scan. I think you said that showed how fast things were growing. Can you tell me about how the color matches that, or should I?
I have no idea. That would be more of a question for Simon.
I'll talk to you later, Simon.
Yeah.
Questions from the floor. Storm.
Thank you. That was a beautiful presentation. I wanted to ask about where's the future with this? Where are we coming up? Like, how have we developed since older times? Like, has the technology grown or more of the knowledge of the sort?
Yeah, so honestly, I feel like I'm saying this a lot, but I didn't research a whole lot about like new advancements. But I know that especially for glioblastoma, Simon was trying to get me to put this in my paper the whole year, and I kept forgetting about it and not doing it. But like especially for glioblastomas, there's this thing called the Stoop protocol, which was made by Dr. Stoop, and I don't know what it is in detail, but I know that it was a really big breakthrough in treating glioblastomas if you compare them like now to like 40 years ago. I know the treatment is very different because of the Stoop protocol. As for like where things are going, I think more and more advancements are being made because there's like lots of people working on it. And I do think looking more into like more like newer technology and advancements would be a really interesting thing to put in my paper, which I didn't do. I don't know if that answers your question, but yeah. Okay.
Great presentation. So I was just wondering that if having a brain tumor would kind of impact the chance of possibly getting like another brain disease in the future, like Parkinson's or Alzheimer's.
That is a really good question. I have so far used this in every question. My research was focused like primarily on brain tumors and not really anything else. I don't know. I think it could because like brain tumors could like weaken your brain, making it more susceptible. But like actually factually, oh, I'm Dr. Seuss. I don't actually know.
Thank you, Ms. LaRoche. That was an amazing presentation. How you were expressing your doubts, but I thought it was an incredible packaging of some really complex information. I felt like I was watching a really good documentary about something that we're all kind of interested in. We hear these stories all the time. So I saw two things happening. One, you were doing this amazing investigation on brain tumors, so you're talking about that, but you also packaged that up in a way like a documentarist. And I know at the beginning of the year you were talking, do I do string theory, do I do brain surgery, that kind of thing. At this point, now that you've finished it, do you feel like you are, you would maybe pursue sort of the medical side of things, more research in brain tumors, or do you see yourself, do you just enjoy packaging up information? Are you looking at something like being a documentarist at the end of this?
Yeah, so I'm not gonna lie, I was really hoping this project would give me more insight in which direction I wanted to go to in life. It didn't. I still have no idea. I know, okay, at the beginning of this year, choosing my topic, like you said, I wanted to do something either with like astrophysics or with like surgery, more specifically like neurosurgery, because those are both things that I find really interesting and like directions I can see myself taking. And I had done a previous project on string theory in a senior seminar, I think, in grade 8. So I was like, okay, we'll go in the other direction. I still don't know. I think both would be really cool. Yeah, documentarists, like not so much.
You're a good storyteller.
Thank you.
Well done, Miss LaRoche. It was amazing. Very, very insightful. My question to you is, because you said that a tumor, when you do surgery for a tumor, I know that there can sometimes not be taken out fully. Mm-hmm. What would be your best course of action? Like, what would you think? Would it be like chemotherapy next, or would it be radiation? What do you think would be next for treatment if it was left over?
Most commonly for like post-surgery, I think is radiation. So yeah, you would go in and resect as much of the tumor as like safely possible, and then I think radiation.
Great presentation. I was wondering, since there's like bunch of like different types of brain tumors. Do you know which ones or one of the like really bad ones and like what it does?
So those glioblastomas were definitely one of the worst, and that's kind of why I went over them, because they're a big problem. Because not only are they like really, really aggressive, they're also super hard to treat, and there's not a whole lot of treatment for glioblastomas, which makes them really dangerous. Yeah.
Ms. LaRoche, does it depend on the shape of the tumor? What makes it more treatable?
I think definitely, yeah, because if it's more like, not like localized, but like contained, I guess. Like think of like a star versus like a circle. A circle is going to be a lot easier to remove because it's more straightforward. A star, you have like all these different places going to all different parts of the brain, which could make it a lot more risky trying to remove.
All right, hi, sorry, another question. I don't know if you covered this in I don't remember if you did it in your slideshow or if you did it in your paper, but if I have a history of brain tumors in my family, do you know the genetic risk to that, or is it just sporadic? Like it just...
I think, I mean, cancer in general usually can run in families. Like it can, like if you have like a genetic history of cancer, I think can make your risk increased. I think brain tumors, since they can be both, well actually most, but okay. I think, yes, I think it definitely genetics can play a role.